Okay, today we're going to be talking about Chapter 11, Airway Management, and that's out of your AOS Emergency Care and Transport 12th edition textbook. The primary component of caring for patients is ensuring that they can breathe adequately. When the ability to breathe is disrupted, oxygen delivery to the cells and the tissue is compromised. Oxygen reaches body tissues and cells through the respiratory system and the circulatory system. The respiratory system consists of all structures that make up the upper and lower airway. So on page 419 in your book, you have a diagram here. It's 419. It's going to be figure 11-1, and that shows your nasopharynx, the nasal passageway, the pharynx, the oropharynx, your mouth, your epiglottis, and the larynx, which is called the voice box. And then the lower airway consists of the trachea, the bronchioles, the main bronchi, left and right side, and then the bronchioles go into the alveoli, into the lungs, into the alveoli, and then your diaphragm, which makes up the lower airway. And again, that's figure 11-1 on page 419. So as we go, just going to do a little bit of a review, a bigger picture so you can see. And this is on page 421 in your book. You can see the nose, the mouth, the oral cavity, the pharynx, and the larynx, which is, again, the voice box. The lower airway functions to deliver oxygen to the alveoli. And the lower airway includes the trachea, the bronchi, and the lungs. Now, the bronchial tubes off the trachea, which is your windpipe, and then you break down into your left and right bronchial tubes, and then they break down into the bronchioli and the bronchioles, which go into the alveoli that are inside the lungs. So the trachea is a conduit. It transports, it's just basically your windpipe, and that's this right in this area here, okay? And the bronchi are supported by cartilage. They distribute oxygen to each lung. So here you see, in this picture here, you're going to see this on page 422. It's figure 11-7 in your textbook. You can see the trachea that comes down. Then it forks off, which is called the carina, which goes into your left and right bronchi, which breaks down into the bronchioles, which enters the lungs and attaches to the alveoli and exchanges. That's where the exchange takes place. Okay, bronchioles are made up of smooth muscles. They got to be a smooth muscle so that air can flow smoothly in and out of the structure. Then the smaller bronchioles connect to the alveoli. Oxygen is transported back to the heart and distributed to the rest of the body. So here you're seeing a picture of the mediastinum, which it's the center of the thoracic cavity, and that is what contains all your great vessels. Your heart, your great vessels, the esophagus, the trachea, the bronchi, and the many nerves that run down the spinal cord. When you remove these, when you remove the lungs, this is the mediastinum right here. Here's your heart sitting right there. You have the bronchioles that break down into the lungs. You have your vena cava. You have your aorta that splits off, and then the nerves run down the middle. So that is located in the mediastinum. That's the center of the thoracic cavity. The respiratory and cardiovascular systems, they work together to ensure a constant flow of oxygen and nutrients gets delivered to the cells. And then it's also responsible for taking the waste product and the CO2 away from the cells so we can exhaust it from the body. You'll see there's three functions, and we're going to give you the definitions. The ventilation is the physical act of moving air in and out of the body, okay? So how that happens is the intercostal muscles will constrict, bringing the chest up and out. The diaphragm will drop, and making that thoracic space a negative pressure. So with that negative pressure, positive pressure outside, air will come into the lungs. And then and that is called an active process because we're using energy. We're using energy in the muscles. As we exhale, the intercostal muscles relax, the chest comes down, the diaphragm relaxes and comes back up into its proper position, and that creates a positive pressure in the thoracic cavity, and we exhale. That is called a passive action because everything is relaxing at that point. The next thing we're going to drop down to is the respirations. The respirations is the actual exchange of oxygen and CO2 at the alveoli. And then oxygenation is when the oxygen is carried in the bloodstream out to the body. So here on page 427, table 11-11, is just showing you a picture of what I just explained, that actual exchange. Air comes in, it's exchanged in the capillaries in the alveoli, and then the oxygen is carried out to the body, and then the waste product is exhaled out through our respirations. Again, this is just another example of respirations. Respirations is where you can see the red blood cells carrying oxygen. Oxygen is given off into the cell, and then the waste product is given off into the bloodstream, and carbon dioxide is carried out through the respiratory system. Okay, factors in the nervous system. Chemoreceptors monitor the oxygen, carbon dioxide, hydrogen ions, and the pH in our cerebrospinal fluid. The air and the blood flow must be directed to the same place at the same time. Ventilation and perfusion must be matched. Failure to match is the cause of most abnormalities of oxygen and carbon dioxide exchange. So we're going to go back to this slide here. The reason why is because these chemoreceptors, they're measuring all these levels, and they're maintaining a constant balance within our body. Now, what triggers us to breathe primarily is the level of carbon dioxide in the system. And that is, those chemoreceptors are located in the medulla oblongata of the brain stem. So what it does is it measures the CO2. When the CO2 levels start to get too high, then that triggers us to breathe. We exhale the CO2, we breathe in the oxygen. So factors affecting our pulmonary ventilation. Intrinsic inside, okay, within the system, infections, allergic reactions, unresponsiveness, which is the tongue obstruction, where if your tongue is a muscle, so when patients go unresponsive and they're laying back in a supine position, the tongue has a tendency of sliding back into the back of their throat, and it partially blocks the airway. Extrinsic, outside of the body, is usually trauma. So atmospheric change in pressure. So if you went from here to, say, Colorado, and the air is much thinner, so then that's going to affect our ability to have good respirations. Partial pressure of O2. Internal factors inside the body, pneumonia, pulmonary edema, COPD, and diseases within that category that fall under COPD. Circulatory compromise. So trauma emergencies can obstruct blood flow to the individual cells in tissue. And how that is done, one, as it's listed here, simple or tension pneumothorax. And when we get into chest injuries, chest trauma chapter, we'll talk more about the simple and tension pneumothorax. A pneumothorax just primarily identifies that there's air in the chest. Now, a simple intention, as we'll talk further about this, in the chest injury chapter, tension is just, it applies tension in the system, so it's going to put pressure on the vessels in the respiratory system and in your thoracic cavity. An open pneumothorax is when you have an opening in the chest and the air is allowed to move back and forth through that hole. A hemothorax, where pneumo is air, hemo is blood. So when we have hemothorax, that's a buildup of blood in the thoracic cavity, which is putting pressure on within the thoracic cavity, which is going to interfere with our ability to breathe. Then we have a hemopneumothorax. Big word, but all we have to do is take the pneumo and the hemo and put it together. So hemo is blood, pneumo is air, so that's blood and air within the thoracic cavity, which is your chest. So, other causes, we can have blood loss. So if someone gets an injury and they're bleeding externally or internally, as we lose that blood, we lose the ability to carry oxygen throughout the system. If we lose the ability to carry oxygen throughout the system, we're also losing the ability to get rid of the CO2. So CO2 levels can start to climb. We also lose the ability to feed the tissue, so get nutrients to the tissue and waste away from. We have anemia, where during certain conditions within the body, the blood loses its ability to carry oxygen. So hypovolemic shock and vasodilatory shock. When we get into the shock chapter, chapter 13, we'll talk more about getting more in depth in the shock. But hypovolemic shock is a low fluid. It could be body fluid, the plasma, or it could be blood itself that we're losing out. Vasodilatory shock is when your vessels dilate for some reason. They just enlarge and get bigger. Your blood pressure drops. We haven't lost any blood, it's just that the pipes get bigger, so now the pressure within the vessels drops and then we lose our blood pressure. It also generated procedures, CPR, nebulizer treatments, endotracheal intubation, and continuous positive pressure treatments to the patient. When we're doing patient assessment, we got to recognize, is the patient breathing adequate or not? So when we're assessing their breathing, we're looking at three things: rate, quality, and rhythm. The rate, you see here for an adult at rest, the range is 12 to 20 breaths per minute. Then we're going to look at the rhythm. Is it a regular or irregular rhythm? Now, if you look on page 434 in your book, you have Chin-Stokes breathing, which is an irregular. They start off breathing normal, and then they pick up, they go faster and faster, then it drops off, and there's a period of apnea. Apnea means that there's no breathing at all, and then that pattern starts all over again. You normally see this pattern in patients who have had a stroke or some type of head injury. So like I said, apnea is just not breathing. Dyspnea is difficulty breathing. And why is the breathing difficult? Well, we're going to get that from listening to lung sounds and getting a good history from the patient. Is this an asthmatic? And then when I listen to lung sounds, I hear wheezing. So we're going to look at the different types of rhythms. Kuhl's-Moll respirations. That is a diabetic patient. And then we're going to look at the quality. Now, when we're looking at quality, when we're assessing the quality, one of the things we want to look at is, do we have a good rise and fall of the chest? Is there lung sound? What are their lung sounds? So snoring is generally, like I said earlier, the tongue is relaxed and it slides to the back of the throat and it causes a snoring sound. So that's a partial airway obstruction. We have wheezing. Wheezing is generally you hear it upon exhalation, and that's your asthmatic. It's usually, that's coming from the lower airway. You may have stridor. Stridor is an upper airway, partial airway obstruction, and you hear that primarily when they inhale. Crackles is a moist sound. It's like putting milk in your bowl of Rice Krispies, that crackling sound, that's the alveoli popping. You have rhonchi, which is fluid within the bronchioles and in the alveoli. That sounds like if you take your hair and rub your fingers against your hair, rubbing your hair between your fingers, that sound simulates rhonchi. So recognizing abnormal breathing, fewer than 12 breaths per minute. And in your book on page 353, it gives you that if they're breathing less than 8 with distress, then we have to assist their ventilations with a BVM. If they're breathing greater than 28 breaths per minute with distress, then we would have to take over that rate and try to use that BVM and try to get that rate down. Is it irregular? So what's the rhythm? Diminished, absent, or noisy lung sounds, what I just spoke of. And then the reduced flow of expired air at the nose and the mouth. So when we're assessing, again, Good rise and fall of chest, what's the lung sounds, what is the pattern, and what is the rate. So other things, unequal or inadequate chest expansion, increased effort of breathing. So increase, you can see if you bare their chest, you'll see the intercostal muscles, the muscles that run between the rib cage, are being pulled in. You'll have up around your clavicles, that is being pulled in, because as the muscles pull hard to try to expand the chest and get a bigger space so that you can breathe better, these extra muscles are at work. Shallow depth, the skin. When we look at the skin, is the skin pale, cyanotic, cool, or moist? Now, when they're cyanosis, or if they're cyanotic, that means they have a blue-gray color to their skin, which is a sign of hypoxia. So once we see that, we know, okay, they're either not taking air in properly, or the body's not using it once it gets into the system. So through our assessment, we have to evaluate what's going on and see, can we correct or stabilize their condition. So here's a picture of the chin strokes, and that's on page, I think I already said that, but it's on page 434 in your book. Ataxic respirations, again on page 434. Kussmaul respirations, and then anything else that's going to affect their breathing. It could be the atmosphere itself, the surrounding area that they're in. There could be gas in the environment that's interfering with their breathing. So even though the patient may be ventilating appropriately, so remember, ventilating is just mechanically moving air in and out, the respirations may be compromised. So there could be fluid in the lungs. There could be an obstruction to the upper or lower airway. So there are different patterns and different scenarios, either trauma or medical, that we have to evaluate how well they are breathing. So when we're assessing someone's breathing, we're going to evaluate the patient. We're going to primarily assess their rate, quality, and rhythm. The pulse ox is a tool that we can use, and basically we put it on their finger, and that's going to measure the amount of oxygen that is bound to the hemoglobin in the blood. Now, the drawback here is it's just telling you what is available. It's almost like a gas gauge in your car. The gas gauge tells you how much gasoline or how is in your tank, but it's not telling you the quality of the gas. There could be water in that gas that's going to interfere how your car runs. It's not going to measure how the engine is burning the fuel. It's not going to measure how well the engine is running. It's just telling you what is available in the system. So with the pulse ox, it's just telling you what is available to that hemoglobin. That's oxygen that's attached to the hemoglobin. It's not going to tell you how the body is using the oxygen. That's going to come from your patient assessment. Assessing the rate, assessing the quality and the rhythm, their mental status. And all these things combined is going to give you a story of how well they're using that oxygen. Now, if everything is looking good, if their lung sounds are clear, the rate is normal range, you have good rise and fall of the chest, skin color is good, mental status is good, and you're getting a reading of 98, 97, then that's all consistent. But if you're getting a reading of 97, 98 on the pulse ox, and you have a patient who is struggling, they're in the tripod position, say, they're in a position where they're trying to make their chest bigger, you hear wheezing, you see intercostal muscles, they're sweaty, they have cyanosis of the lips, then you know that it's inadequate, and that reading is not telling you what's really going on. So you gotta assess the patient, go off of your patient's findings. Next device, you can measure the CO2 levels at the end of the exhalation. So it's your capnography that you're going to be measuring. And in your book, they speak a bit of capnography, and that's on page 437 and 438. It gives you a diagram. This is more of an ALS skill, but it gives you it shows you a diagram of, and here's your capnography. And in the bottom, you see the yellow circle, and on page 439, it shows a breathing pattern. So the normal range is 35 to 45 millimeters of mercury, and then you're going to look at the pattern. Again, this is a ALS skill. So if you see a pattern where it comes up, you have a flat top like, and it comes down, and it just comes up and it's being squared off, that's normally a normal pattern. But if the pattern is just constantly up and down, then that's an abnormal pattern. And again, this is an ALS skill. So opening the airway. There are a couple ways of opening the airway. If you do not suspect a C-spine injury, you don't suspect a neck injury or a back injury, then you can use a head tilt chin lift like we used in CPR. That is the best way to open the airway because it's going to make the airway straighter for you, and it's going to be easier for you to ventilate. Now, if we suspect that they have a neck injury or some type of injury to the neck or the back, then we're going to use the jaw thrust. So as you see in this picture here, this is on page 441 in your book, you see that the tongue is relaxed and it has slid back into the airway, partially blocking the airway. Now we got to open the airway to move that tongue out of the way. So here we're showing the head tilt chin lift. Again, that's on page 441, and it goes over to page 442 in your book. So what they're going to do is lift up the chin and tilt the head back, and that's going to bring that tongue up and forward, and that's going to bring it out of the airway. Now we have an open airway. But now we got to maintain that position as we ventilate. And here is your jaw thrust. This technique is if we suspect that they have a neck injury, we don't want to move the head, then the head's going to stay still. We're going to put our two fingers here underneath their jaw, and we're going to lift the jaw up and push the chin back with our thumb, which is again going to bring the tongue up and forward out of the airway. And then we have suctioning devices. We have a handheld one. You have, in the far picture, you have the pump, a portable suction. It has a battery with a pump, and it just creates vacuum. And then we have the in-house, the suction system that's within the ambulance itself. So we'll go with suctioning in class when you guys come for your week, hands-on. We'll do suctioning. We'll practice this in class. If you look over on page 444 and 445, it talks about the suctioning. When we do a suction, there are two different tips. There's a rigid tip and there's a soft tip. So here we have the rigid, you see off the blue one, and then we have the soft, which is curled up. The rigid one is called the yank hour or tonsil sucker, as your book puts it. And then we have the French, which is the curved one there. Okay, to inspect the equipment, make sure the suction unit is working. It should be no more than 300 millimeters of mercury as you test it on the gauge. When we are suctioning, we're going to put our tip, either the soft or the rigid. It's going to go into the ear, into the mouth. Once we go in, we're going to apply suction. We're going to suction for no more than 15 seconds for the adult, no more than 10 for the child, and no more than 5 seconds for the infant. So we're going to go in, apply suction, turn in a circular motion, and work our way back out of the airway, clearing all the debris. So remove the catheter, log roll patient to the side, clear the mouth carefully if they are vomiting heavily. So if we suspect no C-spine injury and they are vomiting heavily, you can suction the airway, also turn them on their side so that the vomit and the heavy blood flow, whatever, will flow out as we're doing suction. After you do your suction, put oxygen on and oxygenate the patient. In theory, as we are suctioning, we could be suctioning oxygen out of the system. So if the patient produces frothy secretions as quickly as you can, suction the airway for 15 seconds, ventilate for 2 minutes, and then continue this pattern, alternating back and forth. Again, if they don't have a C-spine injury, you can put them on their side. If they do have a C-spine injury, We want to get them on a longboard as quick as we can, secure them, and then turn the whole system on its side to maintain them in line. And we'll talk about C-spine injuries when we get into head and back chapters. So there are multiple different types of airway adjuncts. The first one you can see in this picture here, and that is on page 446. That is your OPAs. So we have the basic airway adjuncts. We have an OPA and an NPA. The OPA is an oral pharyngeal airway, and that's on page 446. It's a curved plastic piece that you put into the airway, and what it does, it holds the tongue up out of the airway for you. We're going to insert a short video into this lecture to show demonstrating how to put the OPA in and how to put the NPA in. So we're going to demonstrate how to put the OPA in. The OPA is an oral pharyngeal airway, and what it does, it goes into the mouth and it holds the tongue out of the way of the airway. So what we're going to do is, first thing we're going to do is measure. We have to measure from the earlobe to the corner of the mouth. So this one here is too big. So when we put it here, we lay it, you can see that the flange is much higher than the corner of the mouth. So it's way too big. If we put it in and it's too big, it's going to push the tongue into the airway. With this one, you can see is much too small. It's below the corner of the mouth. So if we put this one in, it's just going to be another airway obstruction. The tongue's going to slide back to the airway, and this is going to be in the way of us ventilating them. So we use the yellow one, and you can see that the yellow one comes right to the corner of the mouth. Right? So now to put this in, once we measured it, we have to put it in upside down. Once it's in, we'll turn it 180 degrees and it'll pop into place. So first we have to get control of the mouth. So we're going to use our thumb to hold the tongue out of the way. Bring the head back, open up the airway. Then we're going to slide this in. As we slide it in, we're going to turn it 180 degrees and it pops right into place. Now what that is doing, it's holding the tongue up out of the airway. So now we can put our BVM or non-breather mask and ventilate the patient. Okay, the NPA is basically a rubber tube that goes into the nostril. You go primarily into the right nostril because at the tip of the NPA it's on an edge. They call it a beveled edge, and that goes along the septum as we insert it. There we go. Okay, so the next device we're going to do is we're going to put in what they call the NPA. It's a nasopharyngeal airway. This device here goes into the nostril. So if they have a gag reflex and we cannot put the OPA in, then we'll put in an NPA. NPA, when we put this in, we have to again measure. We're going to measure from the ear to the nose to get the average size for that. As far as the diameter of the hose goes, because there are different sizes, we go by the patient's small finger for the diameter of the hole, of the tube. To put this device in, the first thing we have to do is we have to lubricate it to make it slide in easier. Now this device we can put in a patient who is conscious or unconscious, and they can have a gag reflex because it doesn't go that far back into the throat where it's going to bother the gag reflex. So what we're going to do, we're going to go into the right nostril first. That's the primary. So we're going to pull the nose back, put the tube in, and just slide it into place. There we go. And now it's into place. So now when we ventilate the patient, the oxygen is going to follow that tube down to the back of their mouth, directed into the airway. Now we're going to take this out. Keep on running. I'm going to take this out. Let's say we go to put it in and they have a deviated septum. It's pushed over to the right and we cannot use the right nostril. Now we have to go into the left side. So once again, we'll measure it like we did originally. We're going to lubricate it. We're going to pull the nose back, but this time, great, my fingers are slippery. This time when we pull it back, we have to put it in upside down. and we'll guide it in. We'll have gloves on when we do this. We'll guide it in, and then you're going to turn it. And as we turn it, it'll follow the airway into the back of the throat. There we go. Now that it's in, we can go ahead with the BVM and ventilate the patient, and that'll give us direction to the airway. So that's the NPA, the nasopharyngeal airway. And these are located on page 446, 447, and 448. It shows how to put the OPA in and how to put an NPA in. And then, like I said, we'll have a short video attached to this. And this here is the recovery position. Once you've got an airway, if they do not have a C-spine injury, you can roll them on their side, bend their top leg so they're leaning forward using their leg and their arm basically like a kickstand holding them up. And that'll support the head. So now if they're vomiting, heavy secretions coming out, that'll help you maintain the airway. Okay. So we give oxygen to patients who are hypoxic. And whenever there's an airway obstruction, the patient's going to become hypoxic. That means there's less oxygen in the system. There's not that nice balance that we had talked about earlier. So we may have to give them supplemental oxygen to offset that deficiency. So you have different oxygen cylinders. And again, we will have another video. It'll speak of I'll show you the oxygen tank and how to assemble it. Also, when you come into class for that week of hands-on, we will go through assembling and then assembling the oxygen tank. So safety conditions, handle gas cylinders carefully. This is a gas. Make sure the correct pressure regulator is firmly attached. If we puncture a hole in this tank, it can become a deadly missile because the tank itself works off of 2,000 psi. Secure the cylinders when stored in the ambulance. So anytime you have all your oxygen bottles in the ambulance are secured. Your in-house one is secured standing up with brackets, and then your portable ones are going to either be in your airway bag secured, or they'll be secured somewhere else in the ambulance, maybe to the stretcher or an extra bracket attached to the wall. If you notice here, you have a 3-pin system. The 3-pin system on the top of the oxygen tank is unique to medical grade oxygen. So we can't put no other type of regulators on this, and we cannot have a bottle that carries oxygen, but it's not medical grade. It'll have a different stem, so our regulators will not fit that. So that we cannot accidentally give a patient oxygen that's not cleaned and it's not medical grade. So once you put the regulator, so your regulators, it reduces the cylinder's pressure. Remember I said the tank works at 2,000 psi. So it'll take that 2,000 psi and break it down to 40 to 70 psi, so it's more friendly user to the devices we're going to be using. Here are your two different types of flow meters. Okay, we have the pressure compensated flow meter, which is the one on over to the right, over to the left of the screen. That one, you see, it stands up, and that works off of pressure. As we open the valve and oxygen comes in, it'll push a ball up in that plastic tube, and it'll give us a reading of how much liters per minute that we're flowing through the device. The one on the right side of your screen, that is the one that we're going to be using. This is the board and gauge flow meter. When you turn the tank on, it'll go into the first stage of the regulator, showing you the amount of pressure, and then the black knob at the end is the flow meter. It'll adjust liters per minute. And like I said, at the end of the video, we'll have another video installed so you can see how it's all installed and how it works. So hazards of supplemental oxygen, it's combustible. It's not that it's flammable, it's going to explode on its own, but it will feed a fire. So if you're running oxygen, someone's flicking a lighter, it can feed that fire and have a flash to it. Okay, oxygen toxicity. We can give a patient more oxygen in the system than it's needed, and that could have an ill effect on the body. So combustion, oxygen does not burn or explode, but it does speed up the combustion process. It keeps any source of fire, so keep any source of fire away. It'll feed it and keep it going. Make sure the area is adequately ventilated when you're using oxygen, and never leave an oxygen cylinder standing up unattended. If that tank was standing on this table and it fell over and the stem was to crack or break, then, like I said, a little hole, then that 2,000 psi that the bottle works at will make that oxygen cylinder a missile. Oxygen toxicity, not all patients need high concentration of oxygen. If we assess the patient, the rate, the quality, and the rhythm is good, the patient has a clear mental status, their skin vitals are good, and there's no indication for oxygen, there's no need for us to give them oxygen. Oxygen can have a detrimental effect to patients who have diseases that fall under the COPD umbrella. When pulse oximetry is used, again, when you use the pulse ox, make sure you evaluate the patient. Make sure you assess that rate, quality, and rhythm. You assess their skin vitals. You assess their mental status. If the pulse ox, we want to get a 94% or better. If we're getting a good reading and our patient is presenting well, then we know, okay, we can rely on that. But if I'm getting a good reading and my patient is not doing well, then treat the patient, not the tool. It's just a tool to help back up what your direction you're going in. Okay? So we have 3 different types of masks we're going to be using. We have a non-rebreather mask, we have a bag mask device, and a nasal cannula. So here's your bag mask device. You have the bag, you have the mask, and there's a bag, an O2 tubing. When we hook this up to oxygen, the bag will fill up, and then we put it on the patient. And how we adjust this, it runs between 10 to 15 liters. But what we do primarily is when we put it on the patient, we watch the patient breathe. As long as that bag is filled, when they're ready to take the next breath, we know we have it set properly. The next is we have the nasal cannula. That runs between 1 to 6 liters per minute, and it delivers 24 to 44%. Okay? This device we put on patients. We have a medical patient who at home has COPD, and they have it on at home, or for whatever illness they have, but they have it on. So during our transport, we will keep it on, keep the setting that we find at their home, and do our transport. This is a Ventura mask. We don't use this in Massachusetts, but this is a national program, so other states do use this. It's an oxygen mask. As you notice, there's no bag to it, but those little tabs on the bottom, those little devices, there's different colors. Each color represents how much oxygen percentage that system will deliver. So by changing it, it delivers between 24 to 40% of oxygen, which is the same as the nasal cannula. We have masks for tracheostomies. This is a tracheostomy is when either an injury or an illness where they have to close off the mouth and nose, when the patient is not breathing through their mouth and nose no more. They make a slit in the base of the neck here, and they put a tube in, and that's where they breathe. So this patient is going to be breathing off of here. So you can take a mask, use an infant mask, you can put it right over the stoma, and they can go ahead and breathe that way. The other thing we have to check about when someone has a stoma, is it a full or partial? So if it's a partial, that means that we can block that and breathe through their mouth and nose if we have to do rescue breathing. If it's a full, then we'll just breathe through the stoma for them. Basic airway ventilation techniques are extremely effective. As we had talked earlier, how important it is to make sure we have an open, clear, secured airway, and then that we assess the rate, quality, and rhythm of their breathing. If it's inadequate, let me back up. So we're going to assess it So basic airway ventilation is very important. So when we assess the patient, we need to make sure that they have an open, clear, and secured airway. That we're they're able to breathe on their own, or we're able to ventilate for them. And then from there, we have to go to the B step, and where we're going to assess the breathing, make sure that the rate is good, the quality is good, and the rhythm is good. If there's a problem with one of those three things, we're going to have to find a way to either stabilize it or take over. So signs and symptoms of inadequate ventilations or respirations. Altered mental status, which I had mentioned earlier. Inadequate minute volume. Minute volume is the amount of air we move per minute. So to calculate that, you can take your respiratory rate by how much air they're moving per breath, multiply the two, and it gives us a minute volume. Now, we don't have the tools on the ambulance to measure how much air they're moving per breath. But we have the knowledge and the tool to assess the patient. So is the airway open, clear, and secured? Yes, okay. Now we evaluate the rate, the rhythm, and the quality. And that is going to tell us how the the tidal volume, are they breathing adequately? So is the rate between 12 to 20? When we go to the quality, do I have good skin color? Is there any cyanosis? Do I have a good, clear mental status? Do I have clear lung sounds? Do I have good rise and fall of the chest? So are all the components of the respirations really working? Do I have clear, like I said, clear lung sounds? And then we're going to look at the rhythm. Do I have a nice regular rhythm? So if all that is good, then I know my minute volume is going to be good. But if I have a problem with the rate, if they're breathing way too slow, way too fast, then I know that my tidal volume and my minute volume is not going to be well. It's not going to be where it should be. So that's how we can determine tidal and minute volume. And then we're going to look at accessory muscle use and fatigue. How tired is this patient? How hard are they working to get that breath? Here we have a BVM. So if we're working with a patient who is breathing less than 8 breaths per minute or greater than 28 breaths per minute and they're in distress, then we're going to use a BVM. Okay, so here we're going to demonstrate putting the OPA in once again and then using the BVM to ventilate the patient. So we're going to do a head tilt chin lift. I'm going to grab the tongue, open the airway up like we did last time. Put the OPA on the face, roll it in. Once we feel that it bottoms out, we're going to turn 180 degrees, and the device goes in. Okay. Now when we use the BVM to ventilate, the narrow end of the mask goes over the bridge of the nose. The wide part of the mask goes in this little pocket just below the bottom lip. And we're going to use what they call the EC method. Our first finger and our thumb creates a C that goes over the mask. Last 3 fingers makes an E that goes underneath the chin, and we bring the head back. Do a head tilt chin lift, and then we go ahead and ventilate. When you ventilate with the BVM, it's 1 breath every 6 seconds. So it's breath, 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6 1,000, breath. And we give enough air just to move the chest up and down. We don't want to go too forcefully because then we'll force air into the stomach. It's going to enlarge the stomach and eventually push the diaphragm up against the heart, so all your chest compressions will not be effective. If we also ventilate too forcefully and too quickly, we will overinflate the lungs, which would then squeeze the heart, and the heart can't pump properly. So artificial ventilations, we can use a mouth to mask. It's a pocket mask with a one-way valve. We can use that, or we can use the 1 to 2 person bag mask device. The BVM bag valve mask device is designed for 2 people. One person gets a good seal with the mask, the other person squeezes the bag. But the way we use it, because we're limited on manpower in the back of the truck, in the back of the ambulance, one person will primarily be ventilating with the BVM. Okay? So normal ventilations versus positive ventilations. Remember, normal ventilations is the mechanics of our body doing the work that we had mentioned earlier. With the BVM, we are forcing air in. We're putting positive pressure in, and we're inflating the lungs from the inside, okay? And that's how the BVM works. And like I said, I'll demonstrate it at the end of this lecture. Okay, positive ventilation increases thoracic pressure, reduces the blood pump by the heart, puts more volume is required to have the same effects as normal breathing. We got to be very careful when we're using a bag valve mask because we're putting positive pressure into the system. So if we're breathing too forceful or too hard, and as we increase that pressure, we can reduce the blood flow through the heart. Okay, so we can actually reduce cardiac output. If we put in more volume, we're going to have this. We have to put in the same volume. So basically, what we're doing is when we ventilate with a BVM, we are ventilating just enough to move the chest. Okay, we don't have to overinflate that chest and make it big. A couple of things are going to happen. One, we're going to reduce the pump. We're going to put a load on the heart, so the heart's not going to be pumping properly. The other thing is if we put too much pressure into the thoracic cavity, then some of that air is going to go into the stomach. And as we continue to do that, the stomach's going to get bigger, and it's going to grow, it's going to get bigger, and it's going to put pressure again on the thoracic cavity, which is going to interfere with the efficiency of the heart and its beating. So mouth-to-mouth or mouth-to-mask, we don't recommend mouth-to-mouth, we don't teach it anymore, but we do teach mouth-to-mask. And here's your BVM. The bag is the blue part, the mask, and then the bag, the clear bag in the back, that is your reservoir. You can use this device with or without oxygen. If you're using it with oxygen, then the oxygen will be fed into that clear bag, and every time you squeeze the blue bag, it takes, instead of having room air, it'll take the oxygen out of the bag and deliver it to the patient. Gastric distension, like I said, if you're ventilating too forcefully, you can put air into the stomach. Most likely occurs when the ventilation is too forceful or too rapid. It may also occur when the ventilation is obstructed. So we have to make sure that we maintain that head tilt chin lift or the jaw thrust to maintain an open, clear, secure airway. And then we have to ventilate easy. We got to watch the chest. When we give ventilation, as soon as that chest moves, that's enough. And if we're doing a rescue breathing, it's one breath every 6 seconds. So we give a breath, then we count out 6 full seconds. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6 1,000 breath. And I'll demonstrate that again at the end of this lecture. So to prevent and alleviate that, make sure the head is positioned properly. We're not bagging too fast, we're not bagging too forcefully, and then we keep an eye on the stomach and make sure we're checking the head position. Passive ventilation, expansion, contraction, create a pump for air movement. Okay, and that ends the lecture.